Let me see levels. Yeah, it's being annoying.
What is going on?
Bring the mouse down and then bring it close, bring it here and then back over here. And there
Oh,
you go.
look
There
at
you
you.
go. Check 1, 2, 1, 2. Check 1, 2. Okay, there we go. Yep. Automatically adjust microphone volume. No, I do. I want that off, and I want this closer to up here. Check 1, 2, 1, 2. Yeah, because I. Okay, awesome. I'm glad you guys can hear me. And then test speakers. Make sure. Yep, I got signal there.
'02. Whoop. Thanks everybody for coming. It's 9:02. This is the beginning of the SWOG Symposium on Targeting Oligometastatic Disease in GU cancers. First, I just want to say thank you to Dr. Thompson, the entire GU executive committee for suggesting a symposium centered around radiation somehow. And in particular, I think oligometastatic disease has come up repeatedly in the committees as an area of focus. So kudos to your forward thinking and asking us to put this together. My name is James Yu. I'm here just to set the table, and hopefully I can do this in about 3 minutes or so. We have a phenomenal array of speakers that I'd like to get to. So, oligometastatic disease is something that's very interesting, I think, particularly for radiation oncologists. A couple years ago, we asked the ASTRO membership, what are the big questions facing radiation oncology, and oligometastatic disease was one of those in the milieu of immunotherapy, which obviously has been a big kind of area of interest for all of cancer. And so we put together an oligometastatic disease symposium. Dr. Tran was one of our keynote speakers. And if you do a PubMed search of oligometastatic, you can see it's rising like a rocket ship. And so when we think about oligometastatic disease, a couple ideas come up. Some people think it's a game of whack-a-mole, which it certainly can be, in the sense you're hitting metastatic disease and treating them, and then another spot will pop up. Another school of thought is that it's really an iceberg, where you can see the oligometastatic disease, but underneath the surface there could be just disseminated microscopic metastatic disease. But I think the truth is somewhere in the middle, and that's why the first slide was a door. The idea that it presents an opportunity, a therapeutic opportunity to potentially cure patients who traditionally were not thought to have been curative. ASTRO and ESTRO put together a couple years ago, where we were first starting to think about oligometastatic disease, to try and define it. And if you really get into the nitty-gritty of the paper, the definition really is not really a definition, right? They recommended coming away from a number-based definition, and they noted that at the time of this paper, which was only a couple years ago, there were no validated biomarkers that could differentiate between oligo and polymetastatic disease. They recommended imaging specific to the organ site, be able to detect small lesions. That's relatively obvious. But the biggest surprise for me was this idea that oligometastatic disease is really a practical definition, in the sense that regardless of the number of lesions, if you can give the treatment safely and you can deliver an ablative treatment, that could be your definition of oligometastatic. Furthermore, we're learning that oligometastatic is not a monolith. And ASTRO put together a nice kind of tree of potential subcategories of oligometastatic. In the red are the kind of de novo oligometastatic or slow burning oligometastatic. Here in blue are the kind of oligopersistent, and then in the bottom in green are the kind of induced oligometastatic from a polymetastatic state. This is just the schema. That's a little difficult to read. In the interest of time, I'm going to kind of gloss over this, but this is a diagram showing those various oligometastatic states. And what does it mean? Well, there's emerging evidence that not all oligometastatic is the same, that the pace of disease matters, that certainly de novo oligometastatic disease has a better prognosis than those that were induced to be oligometastatic. A couple years ago, at the end of that symposium, I put together this slide to kind of show the state of practice at the time. In 2019, we really were based on clinical definitions saying, okay, this is 3, this is 4, it's oligometastatic. Now we're discovering the pace of disease matters, and in the future, perhaps we'll be treating by multiple different categories of oligometastatic. In 2019, radiosurgery technique was, kind of all over the place for the treatment of metastatic disease, but as investigators like Dr. Tran and Dr. Palma and Gomez and the clinical trialists in oligometastatic disease have kind of investigated this in more detail, we're going to start to codify what the proper treatments are for metastatic disease. And the treatment is getting a little easier in the sense that the physical labor on the part of the radiation oncologist is also getting easier with auto-segmentation and artificial intelligence. Our imaging, we've all experienced this, has gotten better. Right? PSMA PET is spreading like wildfire across the country. and perhaps even more bespoke PET tracers that look at, for example, T cells that are activated, immune imaging biomarkers may start to be disseminated more across the country. And finally, how do we integrate systemic therapy? We have a couple wonderful speakers who are going to talk about this as well. So the way we envision this is in two parts. The first part, Dr. McConkey, Dr. Tran, Dr. Neja, and then Dr. Solanki and Dr. Fitzgerald will talk about kind of the schema, the underpinnings of treatment for, and the practical considerations for, this is a trials group, right? Mounting a potential clinical trial investigating oligometastatic disease. And then we're going to have 3 examples of potential clinical trials. Dr. Kuntz is going to speak to us, I think, remotely about the ongoing Promethean study. Chad Tang, Dr. Tang is going to speak about an oligometastatic renal cell concept. And Dr. Kirchner is going to present a study that he's presented to the GU group a couple of times before, a developing study, IO care. And then Dr. Hamstra is going to do an elaborate dance and with fireworks and scarves. It's really breathtaking at the end for about 5 minutes. So without further ado, Dr. McConkey.
Well, I'm super excited that you folks invited me to join you today because this is admittedly a little bit out of our lane with respect to bladder cancer management, but my whole clinical team is very, very excited about trying to explore whether we can apply some of the same concepts you've learned in prostate and now renal to the management of patients with metastatic bladder cancer. So from a 40,000-foot view, metastasis across different cancers looks pretty similar. So there have been some really, really great studies published recently, including a pan-cancer study from Memorial Sloan Kettering. They've kind of reinforced what we thought we already knew. So back in 2010, you'll remember the Taylor paper in prostate kind of argued that genomic instability was a big driver of badness. That remains the case today. You see a fraction of genome altered and whole genome doubling is often associated with metastatic spread across cancers. And then back when I was at MD Anderson, we had Tim Thompson over at Baylor focusing on P53 as a potential mediator of prostate cancer metastasis. That's still center stage, and Fu has looked at this as well more recently, along with some other players that we were pretty familiar with already. However, this idea that there may be distinct biological mechanisms of metastatic spread, and in particular, recent work that you're all familiar with in renal cancer about the possibility that there are different patterns of spread that have different kinetics, raises the possibility that maybe across all GU malignancies, we'll see similar genetic and biological distinctions between tumors that progress rapidly. Patients with those tumors may have subclinical, widespread metastatic disease at presentation, versus those that are more like the ones that you've studied in clinical trials in prostate, where progression seems to be more slowly developing, and the possibility that ablative approaches to both the primary tumor and oligometastases might have major clinical benefit, might even potentially be curative. So to give you an example, this paper you should all read. It's pretty dense. Another in a long line of beautiful studies from Swanton's group, starting with the New England Journal of Medicine paper with heterogeneating primary tumors that was just transformative at the time. We still refer to that as a kind of the pioneering study on this work. But essentially, the bottom line from this study is that, in renal cell carcinoma and presumably in other disease states, certainly probably in bladder, we have differences in progression rates that are driven by differences in genomics, such that rapid progression seems to be driven by clones within the tumor that change very rapidly. They evolve extremely quickly over time. There's a catalytic mechanism in them that makes them different from the other kinds of tumors that develop and evolve more slowly and through kind of a sequential mechanism of action, more akin to what my own mentor, Josh Fidler, thought about when he thought about the decathlon mechanism of metastasis. I think these are the tumors that might develop metastatic potential over decades, whereas the first kind, the rapid progression kind, might even present with subclinical metastatic disease. So again, Fu has been studying this. I think I would encourage all of us to continue working on this problem. I think that doing work on matched primary tumors and metastatic deposits, maybe reviving rapid autopsy programs, whatever we can do to understand the genomic characteristics of tumors that seem to be more limited in their metastatic potential versus tumors that have high metastatic potential is really important for us to continue to work on. So the other issue is that, as we just heard, there are different patterns of metastatic spread too, the ones that come out of the gate metastatic and the ones that evolve after therapy, whether it's ablative therapy or systemic therapy. And so there are good examples in prostate and breast where applying pressure through the use of hormonal agents causes changes within the tumors that change their biology dramatically, ARNA amplification mutations in prostate and ER alterations in breast. We're applying pressure now with immunotherapy in renal cell and bladder almost automatically now. We're also applying other agents that are novel with unknown mechanisms of action. And presumably this is also going to change metastatic potential through ways that we still need to understand. So I do think there's a potential role for disease consolidation in all GU malignancies. I just need to know, we need to know in whom to use it. I think that we have ongoing and proposed SWOG trials to define this, and there's also work going on in renal. I think that Fu's work with Oriel and other work has shown there's a definite survival advantage when you ablate all metastases in patients with oligometastatic disease. And I think that we need to decide when to use systemic therapy, and maybe use it cautiously, because systemic therapy changes the biology of the tumors, such that if you don't cure the patient, you're dealing with a completely different animal on the other end. And some of those changes may make tumors more aggressive. I think the hypothesis would be that they probably often do. So we need to develop more tools and measurements. Along with PSMA, we need to develop additional tools and measurements for bladder and renal. So, for example, we're working with Steve Rowe and Marty Pomper at Hopkins to try to develop Nectin-4 agents and other agents that might be able to detect oligometastatic bladder cancer. And then I think, again, as I just mentioned, we have to do a lot more research on primary tumors, akin to what they've done with Tracer X studies. They're very, very complicated studies. It takes a village to pull them off, but I think this kind of work is really critical in defining how metastatic biology may differ from one patient to another and develop genomic biomarkers to detect these different patterns of spread. And most importantly, I think that we need to develop really robust liquid biopsy approaches to detect the biology of metastatic cancer and watch it evolve over time. And also, maybe more importantly, to detect a minimal residual disease. So again, if progression patterns can really change, if the pattern of progression isn't hardwired into the tumor, we have to watch the tumor switch back and forth between different states, as again, we just heard was demonstrated in the workshop that they held in 2019. It may be that oligometastatic disease can be induced by different approaches, and then what does that oligometastatic disease look like on the other end, and what might it imply for different therapeutic approaches. So to this end, focusing on some of the folks I'm most respectful of right now who are working in this area, we have different approaches for liquid biopsies that need to be vetted more thoroughly in SWOG. There's a conversation going on, I talked to Jimmy Ray about this yesterday in the gym, between SWOG and Natera, to maybe integrate their Signatera assays more widely into our clinical trials, perhaps starting with breast cancer. A colleague of mine in Denmark named Lars Dierskot is really doing fantastic work in this area in urothelial cancer. As far as mutation panels are concerned, there are strengths and weaknesses with them. I would point you to Alex Wyatt at the Vancouver Prostate Center working with Martin Gleave and others there, Peter Black from our group, really doing deep, robust research on how mutation panels might be useful in detecting both MRD and changes in tumor biology. Bishoy Faltis at Cornell is doing quite a lot looking at whole genome sequencing for copy number alterations. There's a spin-off from Cornell called C2I Genomics that's doing quite a bit of good work there as well. Methylation, if you work in renal cell carcinoma, you've probably heard of methylation DNA immunoprecipitation. They're started at Toronto and has been picked up by Tony Cherry's group at Dana-Farber. Matt Friedman is involved in that. So that is another really promising technique for detecting minimal residual disease, maybe changes in tumor biology if we can connect methylation to these different metastatic patterns. And finally, CTCs are important, I think, still in prostate cancer. I think in urothelial cancer and maybe in renal cell carcinoma, we're a little bit more skeptical of their value. Amir Goldkorn, part of our group, is doing some fantastic work looking across different liquid biopsy platforms, but he's done a lot of really good work on CTCs and prostate. So this is some of Lars's work. If you use the Signatera type assay, you can actually see very strong prognostic implications. I think if you were to ablate a patient with a metastatic disease and then do a CTC measurement afterward, you would be able to distinguish those patients who are having strong clinical benefit from the approach systemically to those that are not. This is another example. This is Tom Powell's work with Genentech. They're a partner of our GU committee, looking at the IMvigor 010 trial, where the adjuvant therapy was negative and all the patients were enrolled in the trial, but in those that had ctDNA present at the time of therapy, there was a very strong survival advantage. So here you can see without atezolizumab and with atezolizumab, there's a significant survival difference if the patient had ctDNA at baseline, whereas there wasn't if there was not. So again, for monitoring subclinical metastatic disease, the Signatera assay looks very promising. In addition to that, it may be a way of finding that our predictive biomarkers in primary tumors can be rescued in some cases. So across the clinical trial, assignment to molecular subtypes was not associated with any survival benefit, but when looking at the ctDNA positive population, you can see very strong survival benefit in those patients who had basal squamous tumors. And again, there are a lot of different assays out there. I think part of our job is going to be to sort through these through discussions with the companies and investigators involved in this work to decide which kinds of assays, which kinds of liquid biopsy assays need to be applied for different questions. So in terms of a translational medicine approach, I think the approach I would recommend is make sure that you have done a lot of preliminary work, discovery work to determine what the molecular determinants are of rapid versus attenuated progression. And I do suspect we'll find that those determinants are present both in prostate and bladder, in addition to renal. I think we need robust imaging agents, and whether it's enhanced conventional imaging, Elliot Fishman has some kind of Pixar-like methods that he applies to conventional imaging, look very promising, or maybe it's more sensitive PET imaging agents for those of us who aren't using them in prostate. We need to excise or ablate the metastases, use plasma MRD measurements to track metastatic progression, and plasma biomarkers to select systemic therapy. So we should be able to use the same liquid biopsy measurements to determine whether or not to use immunotherapy or not for sure. And for those of us who have other choices there, identifying the predictive biomarkers in the serum is really the plasma is really the way to go post-ablative therapy if patients happen to progress. So I think, again, there's a lot of opportunity for translational medicine here, and our job is probably to do a little homework to sort through what platforms might be the most robust and which companies to engage, if we do engage companies, to take part in our clinical trials. Thank you.
All right, our next speaker is Dr. Fu Tran.
All right, Thank you very much, James and Dan, for inviting me, and SWOG. Very much appreciate this opportunity to present some of our collective work and also just go outside after a long period of time. So they assigned me this task here. I did not choose this title. And I am just a simple radiation oncologist, so I changed it around based on our prior work, and I think this, I'll be able to confidently tell you about how we tried to push the extremes of local therapy alone and what we can learn from that experience. So, for a long time, many of us, and some of us still believe that this is the paradigm for how we think about metastatic disease. There's those folks here who are localized and curable, and those here on the right who are non-curable, and whether they're widely metastatic or low volume, as Dr. McConkey had pointed out, it's still a binary state. Over the course of the last couple of decades, these two gentlemen put forth a different hypothesis that instead of a binary state, it's actually more like a lot of things in nature, it's a spectrum. So if we believe in this spectrum theory, then they're actually a state of prostate cancer in the case of the folks that I treat, cancer state that is along the spectrum that where we know patients are curable if they're localized and treated with curative therapy such as surgery or radiation. But perhaps there's even patients who we thought were non-curable who, when treated with potentially curable therapy, surgery and radiation, can be rendered in that state. So it really begs the question, sorry, my slides are shifted over a little bit. Where are these new lesions coming from? Are the macroscopic mets that we previously allowed to go untreated, are they important for future mets? And we know, Dr. McConkey, David pointed out very clearly that the metastatic process is clonal, oligoclonal, for sure. And this gentleman progresses after a period of time to the state on the right via clonal process. So again, simple radiation oncologist, simple hypothesis. If we intervene early, can we affect a change in that natural history? I think something that's allowed us to test this in the clinical situation with a lot more robustness is something you folks may or may not be familiar with, I'm sure you are, is stereotactic ablative radiation or stereotactic body radiation. It's what is it? It's a form of highly focused radiation. As shown here on this color wash where we're treating a vertebral body met, low doses in blue, very high ablative doses in red. You can see the dose fall off is very, very rapid, over a few millimeters. We can protect organs that are, basically adjacent to the target that we're treating, in this case, spinal cord. So we tested this concept in a trial in Baltimore, and Baltimore is a good working class town that loves their sports, and we had a very long name, but we shortened it up to Oriole, which I think was probably the smartest thing I ever did, because people seem to remember it a lot better. But it's essentially that clinical trial randomized where we took patients who had oligorecurrent castration-sensitive prostate cancer, which prostate cancer that had already been treated, unfortunately failed surgery or radiation, had biochemical recurrence, and then on conventional imaging developed 3 or less metastases. Randomize those patients 1 to 2, 1 to a short observation period, 2 patients for every 1 to ablative SABR. This and STOMP, which is Pete O's trial over from Belgium, are really the only 2 randomized trials where we could look at this effect of local therapy in isolation, where we didn't have to frankly worry about the confounding effects of systemic therapy. Some of the other trials, you're not going to give a non-small cell lung cancer patient no systemic therapy when they have metastatic disease. But it was tenable in this situation. And so I don't know, this might be the only situation in oncology where you could do something like this and get that clean of an answer. So it was exciting for us. We had that short observation period where patients could cross over. because it was scary. And, long story short, it took us about 80 patients to randomize 54, 18 to observation, 36 to SABR. As David had mentioned, there was a PFS benefit, but probably more importantly, from a natural history and biology standpoint, and I won't go into it because of the time limitations, but we used molecular imaging in a way so that we could compare essentially totally consolidated patients, so patients that got all their lesions treated with SABR versus patients who had even one untreated lesion. And this is distant MET-free survival. So by treating all the things we could see on molecular imaging, no new macroscopic METs arose. And then there was quite a difference, as you can see by this Kaplan-Meier curve, suggesting that treating those macroscopic METs is affecting the metastatic process. We could spend all day long talking about it. I would love to, but it doesn't change this clinical result. Remember, this is without systemic therapy. So we are affecting a change by just getting rid of the METs. And others have seen, so in non-small cell, Gomez et al. Have shown that when you do that in the setting of systemic therapy, you can also affect the natural history of metastatic disease and result in quite a pronounced tripling almost of overall survival. And that has been reproduced in some other studies. So some of the things we learned in prostate cancer is something we've called modes of failure. So everybody's familiar with patterns, and we'll talk about in a little bit. Modes of failure are, well, how are they failing? And they actually, conveniently for us, fell into approximately equal thirds buckets. So the first was, and this was, based on Oriel, but a lot of the patients we treated out when I was at Hopkins, we saw that there was about a third of patients that did very well. They were, for all intents and purposes, complete response biochemically. We followed them for many years, and if not cured, very long disease-free survival. So that's class 1. We call class 1 long-term responders. There's class 2 oligoprogressors. So, we zapped 2 to 3 lesions. After a couple of years, 1 or 2 would pop up, and we would zap them again. Kind of the whack-a-mole approach that James had mentioned previously. And then there's 3, where we definitely need to know more about the biology, which is, it's the tip of the iceberg that James showed. So we zapped 3 or 1, and within a few months, they unfortunately had many more lesions. Another natural history aspect of treating patients with SABR alone without systemic therapy is the patterns of care. This is wasn't our work, but it's very representative of our work in that we saw very definitive patterns of recurrence following SABR in these patients, and that if you started out with a bone lesion, 85% of the time you were going to recur in another distant bone lesion. If you had lymph node lesions, kind of what we expect from our anatomical prior knowledge is that if you had SABR treated lesions in the pelvis and you had either a mode of failure of class 2 or 3, then you would fail in nodes that were draining towards, downstream. So we embarked on trying to see if we could modify that pattern of failure by using systemic therapy. In this case, the bone-seeking alpha emitter, Xofigo, or radium-223, as you folks know, which is theoretically an ideal agent to treat microscopic bone mets. So again, following off of Oriel, we opened up our trial randomizing these similar patients to SABR now, plus or minus radium. And again, we're still in Baltimore, so we called it the Ravens trial. And it randomizes patients 1-to-1 with 3 or less mets to SABR this time, plus or minus radium-223. That's a 64-patient trial. It's about 40-odd patients deep enrolled, and hopefully will be done hopefully in the next 6 to 8 months, and then have some data for you folks next year. So summary and conclusions, I didn't talk to you about this because at least from a radiation oncology standpoint, it's kind of boring. SABR is very safe if done correctly. The preliminary data I showed you from Oriel suggests that it has an effect on the natural history of disease just by itself. And STOMP, which was the first trial actually to show that, we were able to corroborate that data. I very much believe that understanding these modes and patterns of failure can help us be rational about our choice of adding systemic therapy, as I showed for Ravens. And then absolutely what Dr. McConkey said, if we have a better understanding of metastatic biology, we'll definitely understand oligomets better, but we can even understand polymets. And if we can target polymets, we can perhaps convert patients to an oligometastatic biology. And as you know, we already have tools to treat those patients. So this was our Baltimore oral team, a number of individuals. Just a plug, we use CAPSeq, which is a type of circulating tumor DNA technology that my old resident colleague, Max Dean out at Stanford invented. And then just acknowledge the folks in my group and our funding agencies. Thank you. Oh, shameless plug I'm at Maryland now, and we have another trial in the de novo oligometastatic space called the TERPS trial. I'm happy to talk to you about it later, but for the sake of time, thank you.
All right. Thanks, Dr. Tran. Fear the turtle. All right. Dr. Aneja is remote. He's going to share his slides remotely. Is that possible?
It looks like it should be possible.
Great.
Can you guys all see my screen?
Yes. No.
Okay.
No, it's on the Zoom, but it's not up on the podium. So can we get the Zoom on the podium? So can we switch this screen to, I'm getting head nods. So for those of you online, we're still waiting to get the slides that we all see on Zoom up in the ballroom. So bear with us for a couple seconds. Alternately, we could all gather around the laptop up here. The other alternative is I could just follow along up here. Why don't we do that? Actually, if you want to switch it back to what it was before, I will bring up the slides up here, and as Sanjay advances.
Yeah, I think I might have added one slide, but it's not a big one, so it's fine.
Well, when it, if Dr. Petrolak were here, there would be a couple jokes, he would keep the room lively. Should we do questions for? Yeah, Dr. Kuniev has some questions.
Yeah, so when we wrote a paper, Mike Milano and I, a number of years ago in breast cancer, so it has some of the characteristics of prostate cancer in terms of its patterns of progression. It's a little different. And had the same exact result where about a third of the women appeared to get cured. This was, I think, the very first paper on oligomets. We had like 100 ladies in the study. And it came out to 37, which conveniently is 1/E, which target theory will tell you means that there was only one unknown metastasis that you didn't know about. And as our imaging has gotten better, when we find somebody who really only has two, they might very much really only have two. And now I'm so embarrassed because I'm forgetting the name of the longtime chairman at UCLA. I was a physicist before he became a radiation oncologist. Anyway, a great fellow. He actually got the GM award, and he actually talked about this whole idea of rate from a mathematical point of view, not necessarily a biologic point of view, and I for sure it's both. But his point was that metastases are a rare event. And so rare events mean they don't happen a lot. So you get one metastasis, and then you have one metastasis for a real long time. You don't go from 1 to 1,000 on the next scan. That doesn't happen. So the idea that it was, and he thought it was Fibonacci. So you have your primary, and then you get one met. And now you got 2 tumors, now maybe you get 2 mets. And now you got 4 tumors, now maybe you get 8 mets, you know, and like that. And so he viewed it that way. And we did write a paper, we had a whole volume of seminars that we put together where we actually talked about ideas like that, including the idea of downstaging patients to oligo status using systemic agents of various sorts so that they really were oligo for those people who don't believe that oligo exists. And I think that's a good story for thinking about how we manage these, is that particularly when there are 5 or fewer, that's when you start getting cures. And maybe that's sort of a threshold for when you start getting too fast to Fibonacci. And if you don't believe in the Fibonacci, then you believe that, you must believe that the non-visible mets, as we get better and better at detecting them, are treatable.
I think, you know, certainly there's a role, there is a role for mathematical modeling of the rate of metastatic disease and, you know, even, for example, the rate of mutations occurring, you can kind of back calculate when certain mutations you see in, for example, the autopsy specimen, et cetera, occurred in time in this like kind of evolutionary biology way. Folks like Jeff Townsend at Yale and are doing these kind of evolutionary math. And looking back at the technical table, why don't we just switch back to the way it was and I'll just do the slides.
That works.
While we're waiting, I just want to mention that Dr. Kuniev actually has a classic paper that described why many of us use 3 or 5 as the cutoff.
So I think they're still working on it. Oh, Dr. Thompson's come.
Oh, good.
You got something intelligent to say. I was just going to ask. We have a trivia question. Which James Bond movie was that?
It's the urologist's favorite. And at Hopkins, they used to have the Golden Finger Award.
I was just going to comment, we also had a paper on prostate cancer looking at the number of metastases. Yep. And if you had 5 or fewer, you lived as long as people who had 0.
Oh, terrific.
And so the hypothesis we wrote at the end of that was not that there are lots of interpretations, right? But the hypothesis we said is that if you keep somebody from going over 5,
okay, then
they would get to live as long as the person who had 0. Because other than that, it was in the group over 5, that was the major force of mortality. Right?
All right, we're going to proceed. Go ahead.
Are you going to be able to do the slides or
no, yeah, we can see your screen, so go ahead.
Oh, perfect. Okay, excellent. Hello, everyone. Sorry I couldn't make SWOG in person. Unfortunately, I'm in clinic today. But my name is Sanjay Neja. I'm a radiation oncologist at Yale, a physician scientist. Our group is primarily interested in machine learning and image analysis. And today I'll be talking a little bit about quantitative imaging for metastatic disease and a little bit of the work that we've done in prostate cancer, but also some work that we've done in other sort of related areas in the area of diagnostic imaging. Here are my disclosures. So first today, I'll talk a little bit about our lab, the work that we do. We'll talk a little bit about quantitative imaging, for a more broad understanding of it. Then we'll talk a little bit about, in the case of metastatic disease, some of the barriers and challenges that we have if we are interested in doing quantitative imaging analysis for metastatic patients. And then lastly, we'll talk a little bit about some preliminary data that we have for a recently funded project that's looking at metastatic phenotyping using imaging of primary tumors. So I'm very fortunate to be a physician scientist at Yale and lead an interdisciplinary group of individuals who are focused on the areas of machine learning, data science theory, and the application of machine learning. We really meld clinicians, data scientists, computer scientists, mathematicians, and engineers for the work that we do. We are particularly interested in the areas of deep learning. And just because clinically I'm a radiation oncologist, a lot of the work that we do is in image analysis. So one of our big areas of interest is in imaging-based biomarkers. And essentially our thought is that cancer biomarkers have certain sort of drawbacks. They're inaccurate, they're expensive, oftentimes invasive, and not personalized. And so we feel that imaging that's routinely collected in clinical practice could potentially be serving as a very economical and effective imaging biomarker resource to help us prognosticate our cancer patients. And so typically what we're interested in is looking at pre-treatment imaging. We run typically deep learning analysis on the images or radiomic feature analysis, which I'll get to in a second. And then we try to better understand their outcomes. And the outcomes can be a variety of different things: overall survival, local failure, or also sort of classifying certain things like extranodal extension or presence of tumor, things of that nature. Now, before I kind of get started, I'm going to be talking about two different ways in which we've done quantitative imaging or image analysis on there, on diagnostic images. First is sort of what we would consider more traditional machine learning, which is generally done when you do feature extraction. And so you typically have an input image, you do feature extraction. In the case of diagnostic images, a lot of people call them radiomic features. And then you do classification algorithms to sort of create an output that helps you better identify the image or gain some information from that image. The alternative of that is something else that we're very interested in, which is deep learning. The difference between deep learning and traditional machine learning is that the feature extraction step is gone. And so then the features are essentially thought to be learned through the neural networks. Just because we're a little bit short on time, I'm not going to go through the intricacies of deep learning, but this is just sort of a difference between sort of taking in the raw image, learning features, versus taking in the image, extracting features that have been determined to be potentially prognostic, and then doing our classifications. The benefit of the top is that you don't need as large of a sample size. The benefit of the bottom is that you don't have bias associated with potentially the features that these radiomic features, which people aren't 100% sure are really based off of anything besides physics. So first, we'll talk a little bit about feature engineering using radiomic features. And so the way that the pipeline works typically for radiomic feature extraction is a tumor is outlined as a region of interest. Oftentimes in radiation oncology, that's done in routine clinical practice. And so that's another reason why it's relatively easy for us to kind of extract these from our tumor volumes. These are then, through that, we do pixel level analysis to generate a large number of features over here that are related to shape, appearance, motion, context, things of that nature. And then through that, you can essentially do a lot of machine learning methods. We are able to extract features and manipulate the image and extract larger sets of features. And so for a typical radiomic feature pipeline, you can get upwards of 1,000 imaging features that are related to shape, appearance, and things of that nature. And so 1,000 imaging features for each patient over a large number of samples allows you to have a very high dimensional data set, which is prime for machine learning techniques. Now, one of the barriers to radiomics, specifically in metastatic disease, is actually it's actually a little bit challenging technically. And the reason for that is because a lot of the benefits of radiomic features have been seen in this ability to identify a region of interest, like a primary tumor, and then prognosticate off of that. But the difficulty with metastatic disease is that it's multifocal. And so the question is, how do you really sort of combine all of them? If you have imaging features from one tumor and another tumor, and then one metastatic lesion has certain imaging features that are pronounced, but then another metastatic lesion has other regions that are pronounced. And so how do you kind of make sense of those? Additionally, if we were thinking about multiple regions of the body with different imaging modality types, that's an area that we're still trying to figure out exactly. And so there's a need for us to develop methods to aggregate individual lesion level analysis, i.e. feature analysis, and generate patient level prognostication. Because really what we're interested in is not so much, well, if this person has 7 lesions, one will respond. That's helpful in some ways, but also we're really interested in, is this person really going to have a good outcome, or are they someone who is potentially going to have a bad outcome and we need to be more aggressive with our treatments? And so we actually have looked at this extensively. We published a paper in scientific reports looking at a comparison of radiomic feature aggregation methods for patients with multiple tumors. Our test case was actually patients with brain metastases, but I think that the methods that we've kind of discerned looking at this actually are applicable across the spectrum of cancers, and we've seen it in PET imaging as well as CT imaging as well. And so we looked at a variety of different ways, and we also looked at a variety of different survival models to look at sort of, whether or not this is a consistent finding. And we looked at the unweighted average of all of the, all the features across all the lesions in the person's body. We looked at a weighted average that weighted the size of the lesion by the features. We looked at a weighted average of just the 3 largest lesions, which we felt like their images were probably the most clear and we could probably gain the most information from them. We looked at, the largest lesion, and we added another covariate of the metastasis number. So then that gets us an indication of burden of disease. We looked at the largest one, and then we also just kind of looked at the smallest one as well, just to see whether or not that was prognostic. And what we found is consistently across all of the survival methods, Cox proportional hazard modeling, another variant of Cox, which uses a little bit of a regularization technique, and also a random survival for us, that weighting the average of the 3 largest lesions provided the best predictive ability. And we saw that this was actually consistent across the volume of disease, whether or not you had less than 5 metastases or if you had a large number of metastases as well. And so we feel like this is a method in which we can actually use feature imaging, feature extraction of an individual tumor to develop a prognostic signature of an entire patient. And just to give you an idea, this is sort of a paper that's currently submitted that's looking at prognostication for brain metastases patients on the patient level using radiomic feature analysis plus clinical information. And the clinical information is from what we call the Sperduto nomogram in radiation oncology, which measures sort of prognostic, it helps measure survival for patients with brain metastases using clinical information. And what we find is that when we actually use the clinical and radiomic features together, we're able to not only get a very, very good separation of our Kaplan-Meier curves, but also for anyone who's a survival analysis statistician, we have a very high concordance index, which suggests a very good model a good discriminatory model, which is able to model sort of high-risk patients from low-risk patients and order them in the correct order. So the last thing I'll talk a little bit about is sort of something that we've been working on more recently, which is an unsupervised or more of an experimental project recently funded by Reflection as well as ASCO. We're interested in looking at, are there imaging phenotypes for oligometastatic disease or metastatic patients in general, if we look at the primary tumor itself. And so we've looked at a variety of different cancers, a lot of lung cancer, also a number of breast cancers, and then a little bit of prostate cancer to identify if there's imaging features that we can see from the primary lesion that will suggest metastatic disease versus non-metastatic disease. And does that primary lesion change in its nature? Now, I will say that what we're doing for this is a little bit different than the radiomic feature analysis. We're actually doing our deep learning output. And so that essentially means we're taking the raw image of that primary tumor. We're learning the features on their own. And then we're trying to identify exactly which patients are metastatic and which ones aren't. And so what I have next is a plot from our prostate cancer work that we've done so far. And so what we've done is we actually took the imaging features and we did a dimensionality reduction algorithm called TSNE. It's a T-score T-stochastic net embeddings. Essentially allows us to take a large feature space of a lot of learned features from a deep learning model and put it into a 2-dimensional space and identify clusters of importance. And what we find is that first we're able to identify high and low risk prostate cancer, which is a good thing because it says that there's something on the primary tumor that can help us identify high and low risk disease. And that gives us an indication that potentially we can identify metastatic disease. And then when we actually looked at metastatic versus localized tumors, what we found was that we could actually find separation between the localized and metastatic tumors. And interestingly enough, what we found is these ones with circles are the ones who just have node positive disease. And so those are the ones who are just metastatic in the sense that they had a node, whereas these ones are ones who had nodes and also bone disease. And so there's another potential subgroup here that we have to figure out and sort of explore a little bit more. But we feel like there's some ability for us to use the primary tumor, so the primary prostate, the prostate image, in order to identify which are the most likely patients to potentially develop metastatic disease or already have metastatic disease in the future that can be potentially targeted. And so just a few final thoughts. I think there's promise in quantitative imaging for diagnostic image analysis. Despite that promise, I think that there's some technical challenges which are necessary to translate this into sort of clinically meaningful improvements of our outcomes and potentially integrate these in clinical trials. And lastly, I think these challenges really represent exciting mathematical problems, which we should be sort of continuing to explore in an interdisciplinary fashion with data scientists and clinicians and image analysis experts as well. Definitely would like to thank everyone for the opportunity to speak, although remotely. I'll hopefully be at the next SWOG meeting. And also want to thank all the funding organizations who keep our lab open. Thanks a lot.
Thanks, Dr. Neja. In the interest of time, we're going to move on to Dr. Solanki. If you could share. Or if we could do the same share.
Thanks, James. Can you hear me and can you see my screen now?
We can see you, but we can't see your slides again.
Okay.
1 second. Oh, now we can. We can see your slides if you want to go into presenter mode. There we go.
All right.
Perfect. Go for it.
Great. Well, thank you very much for the opportunity to speak today. My name is Abhi Solanki, radiation oncologist at Loyola and Edward Hines VA Hospital. And I wish I could be there in person, but hopefully next meeting, I'll be able to join you together in a room. So my presentation's really focused a little bit more on the practical aspects as a clinical radiation oncologist, how to make sense of all of this. There's emerging data, really, it seems every 6 months or every conference about oligometastatic disease, and a lot of enthusiasm and excitement about it. But then you're left with a situation of how do you apply this in the clinic? And so that's kind of the approach I took in kind of developing this talk. And for the next 10 minutes, we'll kind of walk you through how I think about it and then how I've actually had to think very carefully about it as we've developed a trial that's open throughout the VA. No pertinent disclosure. So I think it comes down to 3 key practical questions. So who do you select for potential metastasis-directed therapy who has oligometastasis? And built into that is the definition of what is oligometastasis. What is the right target to treat? What's the best radiation dose fractionation that you should use? And ultimately, what is the optimal integration with systemic therapy? And I'm mostly going to speak about the first 3 since there's ongoing trials that are looking into this, as Dr. Tran brought up and Dr. Kuntz will speak about later. So the good news is historically, we really just had anecdotal evidence and historic, prospective and retrospective single-arm trials that showed that metastasis-directed therapy helped patients with oligometastasis, but you never really could establish causality from that. But we now have 3 trials that do establish causality, and a lot of this patient population is in GU cancer. So SABRE Comet was a randomized trial that was phase 2 and screening that enrolled almost 100 patients and had 1 to 5 oligometastases for patients who had oligorecurrent disease with a primary control. And that's the study that really showed a survival benefit when you add SBRT compared to best standard care. STOMP and ORLA were both focused on prostate cancer and both included 1 to 3 metastases, but again, recurrent and with a controlled primary. And both showed that there was a signal of efficacy with metastasis-directed therapy with radiation primarily, but also with surgery in this patient population. But the challenge is that we have these trials, but oligometastasis, as Dr. Yu brought up, is really multiple entities. And this ESTRO consensus classification, I think, it takes a couple of reads before you can really process all of it. And we do have data, but it's only for a limited number of these classifications, really. So the green squares here delineate areas where we already have mature randomized data. So in the de novo oligometastatic synchronous oligometastatic disease and the metachronous oligorecurrent disease, we have data now. And then the S1802 trial is currently investigating in these populations what the benefit of prostate-directed RT is. And so that leaves a large number of patients who have oligometastatic disease without really a lot of data to help guide us about what the best treatment is. And so we have to acknowledge that we do have limited data on how we're helping patients by giving metastasis-directed therapy. And so for that reason, any patient who has oligometastasis, I always prioritize participating in a clinical trial. And there's just so many new clinical trials that are opening up that are available at many sites that I think that this is a reality that you can enroll many patients into studies to help us determine what the best way to answer how to treat these patients are. And then, of course, patients who have a reasonable life expectancy and patient preference is a very important piece of this, especially in prostate cancer, where the impact of hormonal therapy and quality of life is very important. When it comes to specifically the oligometastatic disease state, the strongest data we have, the level 1 data, support metastasis-directed therapy in patients who have metachronous oligometastasis. So patients who have de novo newly diagnosed disease that have synchronous oligometastasis, we don't have that same level of data in GU cancers. In lung cancer, we do, but we don't yet have that. And for all the other patient populations where we don't have that level 1 data, it's ultimately a multidisciplinary decision-making. And a lot of it centers around where we're at with systemic therapy. Are there subsequent systemic therapy options? Is the patient willing to undergo those systemic therapy options? And really, what imaging modality was used? Did you use conventional imaging to identify the oligometastasis? Was it only on molecular imaging? But really, you have to make the right decision for the patient in front of you. And the classic definition was brought up of 3 to 5 metastases, and we use those, but I would say it's kind of loose. And who's to say that 2 lymph nodes that are right next to each other, is that biologically different if it adds up to 6 versus 5? Probably not. And that's why the specific number breakdown isn't super reliable in my mind. And as I mentioned, the randomized data we have available, it actually excluded patients who had radio recurrence in the primary, whether it's in the prostate bed or in the prostate itself, or for really any other malignancy. And what do you do? Because we're actually seeing a lot of this as we incorporate PSMA PET imaging and more molecular imaging gets expanded. We see a lot of patients who not only have oligometastasis, but have local recurrences that you somehow have to salvage if you're going to treat the other sites of disease. The second question becomes, once you identify these patients, what's the right target to use? So SABR, COMET, STOMP, and ROYAL, they targeted the metastasis only. And it was primarily with SBRT-like doses, but as was brought up, a frequent form of progression after metastasis-directed radiation just to the target in nodes is elsewhere nodes. And we know from the newly diagnosed high-risk localized prostate cancer setting that there's some benefit to elective nodal RT in patients who have aggressive but localized disease on imaging. And so it raises the question of, should we always use SBRT, or are there patients who may benefit from some sort of larger field radiation where you're treating high-risk adjacent areas? I think this is something, especially for patients who have newly diagnosed node-positive disease or pelvic nodal prostate cancer with a single isolated met in the periortic area. We ask ourselves this question a lot, but we just don't have great data comparing the details of the radiation. So there's 2 larger multi-institutional retrospective series that have compared SBRT versus an elective nodal radiation approach. Both were in the oligo-recurrent setting and the hormone-sensitive setting, but were multi-institutional and used relatively good imaging modalities to identify patients. And they both showed similar findings with that, which is that there is some oncologic efficacy to treating not only the metastasis itself, but the surrounding lymph node regions, with improvement in biochemical outcomes and perhaps even metastasis-free survival in patients who have limited nodal disease. But it's at the cost of modestly increased toxicity, both grade 2 and actually grade 3. There was really no grade 3 toxicity with SBRT, but with elective nodal RT, there was a slight increase, about 2 to 3%. There's a trial that's ongoing that hopefully in the next couple of years will answer the question, which is PEACE 5, the STORM trial. And that's for patients who have pelvic oligorecurrence and is comparing SBRT to the PET positive disease with or without a pelvic nodal field. And so hopefully that will help us to determine for patients with nodal oligorecurrence if there's a benefit. And this is really what the difference is. And so on the left here, you can see a patient. This is the same patient in both slides, but we're just looking at 2 different types of plan. So on the left, we're treating SBRT just to the nodal oligorecurrences. And on the right, we're treating those nodal oligorecurrences, but we're also treating the pelvic nodes. And in this patient, the patient had prior radiation therapy to the prostate. And so we had to match on a field. And so actually not even treating all of the nodes in order to be safe to minimize bladder and rectal reirradiation dose. So the third question is, once we figure out the target, what's the best radiation dose fractionation? And unfortunately, there's not a lot of data for this either. So now that we have STOMP, ROYAL, SABR, COMET, as well as NRG-BR001, frequently most clinicians use dose fractionations used in those studies, which I think is a reasonable approach. And I think of these as validated because we have both effectiveness as well as toxicity outcomes from that. There is one randomized trial from Memorial Sloan Kettering that compared single fraction versus 3 fraction SBRT. That's a single institution study that serves as really the only level 1 data. But it's tough because a lot of the other studies have used different regimens. And so, how do you integrate that when you're, pursuing different paradigms? And then there's the non-validated resources. So there's a lot of great consensus guidelines that we use, particularly for normal tissue constraints, to help us to decide what the right normal tissue constraints are. And then ongoing trial protocols, which I would argue aren't validated, but perhaps are closer to what you're trying to pursue and have built upon the prior validated studies. and finally, all of us have personal experience and institutional standards that we need to kind of reconcile with all of the above resources. So when we're treating these patients, we used several guiding principles. Frequently, it's a combination of these above resources. We know that one size doesn't fit all, and you try to choose the right dose for the right target for each patient. We know that there are different regions in the body and various critical structures that have differing radiosensitivity to SBRT. One area of extreme caution is actually in the thorax near the proximal bronchial tree. We know that we can actually cause grade 5 toxicity in patients with SBRT, and so caution is important. And so the aggressiveness you do there versus a pelvic nodal recurrence that's far from bowel probably would be different. And I think an important factor is that different radiation oncology centers have different technical and staff strengths and limitations. And so it's important to acknowledge those when delivering treatment and make sure that you can give the safest radiation possible. And always prioritizing normal tissue constraints is important. So taking all of this into consideration, last year we developed a trial across the VA that's open at 16 sites called the VA Starport trial. And this trial is for patients who have oligorecurrent prostate cancer after definitive therapy and have up to 5 sites of oligometastatic disease on any standard of care molecular PET imaging for prostate cancer. And it's a very simple randomization, which is essentially asking the question of, in the setting of standard systemic therapy for metastatic disease, does PET-directed local therapy improve outcomes? And as we developed this study across our sites, and these are the 16 sites, so we wanted to make sure that the radiation details were never a reason why somebody wouldn't enroll a patient on the study. Because the reality is radiation oncologists have very strong feelings about what they think is the best way to treat patients with radiation, as does any physician and as they have the right to. And so it's important to be permissive to allow for people to have a sense of the ability to choose what regimen they give. And so as a result, what we found was that we needed to be very permissive, and all trials that are developed should be permissive of different radiation practices, but also be pragmatic in the sense that you have to have some sort of menu of options in order to make some generalizable conclusions. And since patients who have have heterogeneous presentations of oligometastatic disease in many different sites with many different types of prior treatments, with many different tumor characteristics, the best we could do was differentiate patients into 7 metastatic sites and then create an option for a list of options for each of those sites. And this is what was done in many of the NRG trials that are testing oligometastatic disease. And we also decided, because there is this controversy in an ongoing randomized trial about whether SBRT is better than elective nodal RT with a boost to the gross disease, to offer both so that the radiation oncologist can offer whatever they think is the best way to treat the patient in front of them. And the randomization is really not a specific radiation dose regimen, but just the idea of giving PET-directed local therapy to patients who have oligorecurrent disease. And of course, critical structures are always prioritized over target coverage to observe the do no harm principle. So as part of this study, we did a survey for radiation credentialing to make sure that sites could safely deliver the radiation as part of the study. And what we found is what kind of I expected to find, which is that there's so much variability on how radiation oncologists and centers look at the same benchmark case with oligometastatic disease and what they would choose as their treatment approach. So as you can see here, this patient had 2 nodal oligorecurrences and then a pelvic bone met, and then had prior radiation to the prostate. So the respondents, which is the 16 sites, were split over whether they would do SBRT or elective nodal RT to the nodal recurrences. And then if they did do elective nodal RT, would do an SBRT treatment to the pelvic node. The choice of what would be chosen as the prescription was all over the place. In fact, there was very little conformity between the sites for the nodal disease as well as for the bony disease. And the treatment margins, which because of time I'm not going to talk a lot about, which is really an inherent technical consideration that should be made at the institution level, was also different for each of the sites based on their comfort. And so I think the key conclusion from this is practice patterns vary, and it's important to account for those and actually, I think, embrace them. So key conclusion, from a practical perspective, the clinical setting that has the strongest data supporting metastasis-directed therapy off trial, I would argue, is metachronous oligometastasis, or oligorecurrence in my head. Most of the data we have used SBRT-like regimens, but perhaps there are some patients that may benefit from larger field radiation, and we'll find out through the STORM trial. When planning, do no harm is the first principle, and prioritizing normal tissue constraints over aggressive radiation dose is important. There's great variability in the preferred RT practice details and needs to be considered. And finally, the multimodality role in combination with systemic therapy will be determined through ongoing clinical trials, which will be discussed later today as well. Thank you very much, and happy to answer any questions if there's time, but if not, feel free to shoot me an email.
Sure. Terrific. Thanks, Albie. I don't think we do have time for questions, so everyone please do shoot Dr. Solanki questions via email. Our next speaker is going to be Dr. TJ Fitzgerald from a group called IROC, which is, when we think about the practical aspects of radiation oncology, how do we operationalize that in a cooperative group setting? So Dr. Fitzgerald.
So Jim, thanks. Do you want to put up the slides, or do you want me to work on share screen?
Whichever's faster. Why don't you put on share screen, actually, because we have your Zoom up on the main podium. So why don't you go ahead and share?
Let me give it a try. Let's see. Looks like my share screen's not working, Jim. So
okay. Well.
So yeah.
All right. I will run the slides. Can you see them?
Give me 1 second to get back. I can't see them, but I actually have the talk up. So.
Can we share these slides on Zoom?
Sure.
I have the Zoom screen open. It doesn't look like these are being shared on Zoom.
Looks like
No, TJ, we'll handle it up here, TJ.
Yeah, why don't you go ahead, because I actually have.
All right, now it's the Sanjay and Aja's presentation. You know what? I think it's probably because this. Okay.
Yeah, we may have both hit it at the same time. So
I'm going to close. Okay, great. All right, so I have it up, and
okay, so I'm still looking at Sanjay's, but let's we'll give it our best
Oh.
shot. Is that okay? Now, if you can see them, Jim, and others can, I can give the talk.
Well, here on the podium we can see them, but on the Zoom it says IMS operator has started screen sharing. Okay. Double click. Folks on Zoom, can you put in the chat whether you can see the first slide for Dr. Fitzgerald? It's a different screen.
And actually, Jim, it looks like I just got knocked out. So.
Okay, I think we're there now. Oh no. Okay. Is there a second? Oh, I know what's going on. Okay, I know what's going on. Yeah, I'm just going to do this. All right, come on. Go back to this. Here we go. So TJ, I want you to stop. Oh, so why don't you just, Who's moving the slides on the Zoom? Is that technical? TJ, are you moving slides on the Zoom?
It could be me, Jim. If you can see them, I will just go ahead because I actually have you on the wrong screen, but I can do.
Actually. All right. Well, why don't you just start?
Okay. It says I'm screen sharing, so I'm assuming everyone can see.
Yes, I'll run in parallel. So you just go and I'll run in parallel for those in the room.
Sounds good. So slide one is just an introductory slide for all of us. Appreciate everyone's time today. This is always a great meeting, and kudos to Jim and SWOG for putting all this together. Slide two is just an overall business model for for
So TJ, can you go into presenter mode on your end?
Let's see.
Or switch screen.
Because
See.
so in the bottom right corner, there should be a little next to the minus sign. You can click that.
Well, mine looks a little different, so let me see what I can. Jim, I just got knocked out, unfortunately. So.
Okay, so why don't you keep going with your screen, but when you talk, you have to click this, yeah, okay, click that.
Yep.
Okay, keep going, but you have to show the slides.
Yep, I will. Okay, sorry to everybody, but so this is just the organizational structure for how we manage ourselves. That Quark is housed within the Department of Radiation Oncology and UMass Medical Center. We have a variety of projects, including managing the quality assurance for the NCTN, in large part for imaging and most of radiation oncology throughout the NCTN. And a large component of what we do now is with industry trials as well, many of which include stereotactic therapy. For this group, I'll be more heavily involved in TCIA moving forward, which is important, especially as part of Sanjay's presentation and sort of bringing all the pathomics into the structure that we all want to do for our primary research. Just to give you a sense of where all of this fits into the construct of the NCTN and the NCI. Each of the 5 cooperative groups that are funded, through the NCTN mechanism actually have their own member sites, tissue banks, statistical centers, and operation directives. There are centralized functions, though, which you're all familiar with in terms of the central IRB, but housed within that central structure is a single core that collects all imaging and radiation therapy treatment objects. And that serves as a hub and spoke to all the cooperative groups, as well as a Canadian network system, and the NCORE system fits into this. So all the imaging that, let's say, Sanjay had presented in terms of pre-therapy imaging that we all use to draw our target volumes, and I think more importantly, outcome imaging, is all collected under a single network. And many secondary and tertiary projects have been generated from that activity. So what we do from a core perspective is that we provide site qualification, and this includes all aspects of radiation therapy, and also much of the imaging quality assurance and data acquisition of the slice thickness, sequence imaging, and MR and such are all under a specific QA umbrella. We provide all the trial design and support assistance. So in terms of protocol review templates, in order to harmonize much of what we want to generate from the protocol, we credential into the system, we provide all the data management, and we do all the case review. And much of what I do on a daily basis is pre-treatment review of objects, to make certain that the imaging coincides with the study objectives, the correct imaging is assessed, and the radiation therapy treatment objects are applied per protocol guideline. If you look at the website on the left, all entry points into the cooperative groups and the NCI groups are on your left, but on your right is the industry portfolio that we're currently working to manage. So what I wanted to go over with you is that, you're well underway to having the infrastructure in place to be able to provide the, a nice cohort for doing oligometastatic studies. And you can see there are a variety of sites that we use: GU, lung, prostate, lung, and oligometastasis. And, into some of the other presentation points where there's a variety of site localization. Children's Oncology Group actually ran a very good study looking at multiple metastatic sites in rhabdomyosarcoma. So there's a nimble enough infrastructure in place to be able to manage and triage these components with guidelines in place, for site of disease, fractionation, and such, important to harmonize our objectives. Additional, studies that are now closed that have used, oligometastatic directed therapy include the Alliance Pancreas Trial, Rare Tumor Trial, Sarcoma, Lung, Colon, and Spine. So with this, with the credentialing components in place, as many of you are familiar with through the cooperative groups, that hard credentialing through phantoms has been done through the Houston office. And this provides important infrastructure to make certain that therapy units are calibrated for all the NCTN trials. Many of the industry partners, though, have utilized what I will call benchmark cases. And benchmark is really, let's say a typical treatment case, that the discs will be sent to the site and a treatment plan will be created. And then we score that benchmark case based on the ability to perform appropriate dose to structure. Most of the benchmark cases, as this group knows, are my patients. And so this is an isolated pulmonary lesion that was used to credential institutions around the world for radiosurgery trial, because there are several immunotherapy driven protocols with stereotactic therapy, very much akin to the NCTN that we do. Parenthetically, yesterday, actually, I saw a case from Poland that I had previously approved the case from the Ukraine, and it was just good to see that the patient was able to continue therapy in spite of all the circumstances that they now face. So the benchmark cases serve a really nice purpose in terms of harmonizing at least the infrastructure in place. Now, when you do log on to the website, we have all the pre-therapy imaging, in situ. And what I do for reviewing cases on a daily basis is that I'll review the imaging, more or less visualize what I think the plan might look like, and then open up the RT objects to actually see this point. Important for this group is that we collect all the outcome imaging, so that as we want to start going through some of the pathomics and radiomics of these issues and what these might look like, and especially some of the predictive models that Sanjay pointed out, all of that will be at our fingertips, so that much of this can be used to move forward to help validate our work. Within that, you'll actually have all the dose volume. These are full data sets. And so we will rerun all of the computational analytics through the computerized environment for radiation research to develop a single infrastructure. But certainly, if you have an algorithm that you want to use, these can be repurposed for secondary and tertiary analysis. The pretreatment review plays an important role. As you can see that, here on the left is a single plan that actually on initial review, certainly the target volume and tumor target was covered, but there were normal tissue constraints that weren't being met. So I was able to provide real-time feedback so that as we start think downstream in terms of computational AI algorithms that are predictive indicators for consequence, these will be at your fingertips as well. And you can actually see how these adjustments take place. And as Sanjay was speaking, I was thinking of ways that we could potentially incorporate some of his tools into the quality assurance process. But this becomes an important component for what we do. The meaning of this, I've always found to be important. So that this is a slide looking at a variety of SWOG trials that where we look at whether patients were reviewed pre or on treatment, or whether the trial was designed just to look at the objects after the protocol was completed. But you can see that statistically, there was a real improvement in the deviation unacceptable rate if the patient was seen in a pre-treatment manner. The pre-treatment review doesn't preclude a deviation of final review, because most of the 21 cases were patients that wound up having protracted therapies. But nevertheless, it does have an impact, especially in rare tumor trials where we really need to have all the data in a uniform format, so that when we publish our papers, not only will they have significance, but our data can be believed. So this final slide is just a quick snapshot on a few trials about the number of diagnostic and therapy data sets that we have on site. So as you want to start retest some of these algorithms, a lot of infrastructure is in place right now that we can all repurpose and help us all move forward with these very exciting protocols. So in summary, Jim, I think we have all the infrastructure in place to be able to conduct a clinical trial that you envision, and certainly appreciate everyone's time, and apologize for all the moving slides back and forth. But thanks. I'll stop there, Jim.
Thanks, Dr. Fitzgerald. And so that concludes the first part of the largest part, which was the kind of practical underpinnings of how we will potentially mount a trial evaluating oligometastatic disease. Dr. Thompson, in his infinite wisdom, encouraged us to have kind of some buffer if we did run behind, and we certainly did. And so, believe it or not, we're actually running on time. So thank you, Dr. Thompson, for those very wise words. So the next speaker is Dr. Bridget Kuntz, who is also remote. Dr. Kuntz is going to give us a rundown of the Promethean study. Oh, we're looking at someone's.
Share my screen if it's easier for you.
So you know what? It might be easiest for us if I just run the slides.
Perfect.
But on the Zoom right now, we're reading someone's email. So if we could just go back to the old way where you're showing the slide. There's Dr. Kuntz. So Dr. Kuntz, maybe you should just present.
Yep, absolutely. So I really want to thank you for the invitation and to be able to share the NRG GU11 trial. Now you should be able to see that in presentation mode. Is that correct?
Yep, go for it.
Perfect. All right. Thank you very much for the invitation to present to SWOG. I've never been, so this is my first SWOG meeting. I was somewhat disappointed that I couldn't be there in person, but I really appreciate this opportunity. As sister NCI cooperative group structures, it's very important that we support each other, and I'm happy to be able to share what we've put together. Look forward to your input and support, and as we create a whole portfolio of oligometastatic trials in the GU space. So this study, NRG GU011, was a couple of years in the making. It has been approved and is just opened a couple of months ago. It is a phase 2 double-blinded placebo-controlled trial of prostate oligometastatic radiotherapy with or without androgen deprivation for oligometastatic prostate cancer. And its nickname, although perhaps not nearly as site timely as Dr. Tran's trials, is titled NRG Promethean. This trial is, of course, sponsored by NRG Oncology and funded by the NCI, but it does have additional support from Myovant Sciences. Okay, so just from just disclosures in terms of past consultants with Myovant. These are our study team contacts, just as NRG is asked that we put in that information, and you'll see good comprehensive coverage in terms of several folks helping us with the radiation oncology design. Dr. Tran is translational science chair, and we have Tom Hope from UCSF as our imaging chair. So you've heard a lot of the background as to why we created this study. There has been an improvement with our imaging techniques in terms of the diagnosis of what was previously microscopic oligometastatic disease. And the standard of care is not clear in patients who are M0 by conventional imaging, but are found to have oligometastatic spread by PET. Our trials in the metastatic space up to date have been based on conventional imaging. And so that's really, it creates a window of opportunity for these patients and for us as their clinicians to think about the timing and how we combine therapies. You've also seen in earlier today's sessions that the data regarding the phase 2 trials that have shown that stereotactic radiotherapy to oligometastatic disease can delay cancer progression. And in some cases, the use of ADT, which was based on the STOMP trial. And that's important because ADT toxicity is at the very least an important quality of life issue for men with prostate cancer. We also know that certain types of ADT increase cardiac risk. And so it's something to consider as we look at the portfolio of options that they have. So just another reminder as to the study rationale for why we chose stereotactic ablative body radiotherapy, which, SABRE, we pulled from the trial with the largest data in this setting. If you look at overall patients, SABRE Comet, but I will note that SABRE and SBRT, for the most part in the radiation oncology world, are used interchangeably. So SABRE Comet showed an improvement in overall survival for patients with multiple cancer types, although it included a large minority of prostate cancer patients. And they were randomized to oligometastatic SABRE versus standard of care. STOMP reported that PET metastasis-directed therapy was able to delay ADT, and 34% of men at 5 years were still not on ADT therapies, and reduced the incidence of castration-refractory disease, which we know is an important inflection point in these men disease history. Oriole showed that oligometastatic directed SABRE was able to extend progression-free survival. And particularly insightful in how that trial was designed is that they looked at conventional imaging versus PET staged. And again, for men that were PET staged, the SABRE had a particular benefit. So I think that's important to note as to why we're looking in that specific space, because it truly acts differently than conventional oligometastatic disease. Now, for this study, we are using relugolix as the ADT agent. So I just wanted to spend one slide on why we chose that drug. Relugolix is an oral gonadotropin-releasing hormone receptor antagonist. So it blocks both LH and FSH. Just like other RH antagonists, it drops the testosterone to castration levels very quickly after initiation of the drug. But because it is the first oral agent, testosterone recovers much more rapidly with its short half-life than depot agonists or antagonists. And this was shown in the seminal paper published in New England Journal in 2020, where at 90 days, testosterone had returned to normal values in over half, 54% of men, compared to just 3% in those who were treated with leuprolide. Relugolix is well tolerated. Overall, it has the similar toxicities as traditional depot forms of ADT, but it is noted to have fewer cardiovascular events with LHRH agonists, similar as to what we would expect with its antagonist class. So the study schema for NRG Promethean is that we are looking at recurrent oligometastatic prostate cancer that is detected by PET who have previously received therapy, definitive therapies to the prostate. So that could either be radiation or prostatectomy, whether or not it was followed with salvage radiotherapy afterwards. These men are stratified based on the location of their metastasis, whether they were node only versus bone plus or minus node. I will note that if they are node only, we do require that they have at least one extra pelvic node because we aren't looking at M1As. This is a different population that is truly metastatic. And so we need them to at least be one extra pelvic node. They're also stratified by PSA doubling time and the type of PET being used, fluciclovine or PSMA. We chose not to include sodium fluoride or choline, so we're just looking at fluciclovine or one of the several PSMA agents that are now FDA approved. Patients are being randomized 1-to-1 to either SABR plus blinded placebo for 6 months or SABR plus blinded relagolix for 6 months. The primary endpoint, the primary objective is looking at conventional imaging, radiological progression-free survival. Now that is because it has been best tested in other scenarios and will allow us to compare. However, we also are looking at PET, radiologic progression-free survival, quality of life measures, sexual and hormonal quality of life, measured by EPIC 26, and then also measures from the EQ5D5L, the QLQ 30, and PROMIS fatigue. We'll compare time to salvage therapy, time to castration resistance, and we'll look at local progression, biochemical progression, distant metastases, cancer-specific mortality, metastasis-free survival, and overall survival. And finally, of course, we'll determine the adverse event rates and compare those between the two treatment arms. As an exploratory objective, we are eager to look at what biomarkers there might be that could predict treatment response and long-term disease-free interval. For eligibility, so this was hard thought about what is the right patient group, and based on the data that you've heard already presented, this is where we landed. Again, we're looking in that oligo recurrent space, and you've heard the rationale in previous discussions as to why. They do have to have a negative conventional imaging, so a technetium bone scan and either a pelvic CT or MRI. And that's really based on the data that in conventional M1 disease, there's a stronger role for ADT. For the positive, what we defined oligometastatic disease as 1 to 5 lesions, and we did allow, as I think Dr. Solanki had mentioned, that we count those lesions based on proximity. They're radiologically distinct; they are separate lesions. We have a maximum PSA of 10 and a minimum based on the treatment definition, the primary treatment definition of failure. And we are requiring a testosterone of at least 100 nanogram per deciliter because we really want patients to be not hypogonadal. So they may have had previous ADT and that's fine, but they need to not be at castration levels of resistance and have a reasonable testosterone recovery because we are looking not only at, we wanted to be looking in the castration sensitive space and we want to be looking at quality of life. So all patients will undergo radiotherapy to all metastases, and then they're randomized. Of course, the study intervention is placebo versus relagolix. Relagolix or placebo begins on the same day as radiotherapy and is given a loading dose and then treated at 120 milligrams daily for 6 months. And then radiotherapy, this was a challenging one because, again, similar to the VA Starport trial that Dr. Solanki described, we didn't want radiation to be the barrier, but we also know that clinical trials are often the sources of how to treat patients, and we wanted to provide some guidelines so that the SABR would be high quality. So what you're seeing here is based on the metastatic site, whether it's spine, non-spine osseous, or node soft tissue, and based on the number of fractions that the treating physician chooses to deliver, what an appropriate dose would be. So for example, for the spine in a single fraction, we're recommending 16 to 20 gray. But if 3-fraction regimen is preferred, the total dose would be 21 to 30 gray and fraction sizes of 7 to 10 gray per fraction. So we try to be this is not meant to be overly prescriptive, but again, trying to provide some measures of quality. And the goal here is that these all have a biological equivalent dose of greater than 100. So that is the study. It was activated in December. So far, we're still in the ramp up phase, so we don't actually have any enrollment yet. But we have a large number of sites that are pending. So I'm hoping that means that we've got significant excitement about this trial. And if we have any time, I'd be happy for questions, or I'd be happy to field them through email or the chat.
Terrific. Thanks, Dr. Kuntz. We actually need to move on, but please do send questions to Dr. Kuntz about Promethean. Our next speaker is going to talk, Dr. Chad Tang. Okay, and Dr. Tang, if you're on, why don't you run the slides on your end and I'll just parallel.
Yeah, that's great. Can you see my slides now? I just shared it.
We see your slides. If you move forward one and back. Yeah, so I'll just go parallel with you.
All right, perfect, wonderful. All right, thanks everybody for the opportunity to talk at this meeting. I'm here to talk about non-prostate cancer, I guess, another GU malignancy, renal cell carcinoma, and talking about the interest and activities in the oligometastatic space in this disease. So this was a slide that was brought up earlier, this whole TRACER RX renal study. There's a number of papers in this area, but it's a very interesting paper, as was brought up earlier, and it shows that there is this phenomenon called attenuated progression. It's actually genomically characterizable, where you have a lot of heterogeneous clones emerging, such that maybe one could almost consider these as a series of local diseases as opposed to one systemic-wide metastatic disease. On the flip side, there are obviously patients where you have rapid progression, where it's almost definitely systemic disease up from the front. Now, the real trick and the real challenge for everybody knows is how to differentiate these two patients. Maybe genomics something to do with it, maybe not, but it does bring some interesting hypothesis. So with regard to renal cell carcinoma, if you look at the current NCCN guidelines, and this didn't change in 2022, but what you can see here is for regardless of histology, you have a number of options that are all supported, including clinical trial, first-line systemic therapy, which are usually IO, TKI, IO doublets, mastectomy, radiation, or ablative techniques, use IR ablation, or best supportive care. So you can do anything if you like in the first line renal cell carcinoma space and have NCCN back you up, because I can't think of another option outside of these options, systemic therapy, supportive care, local therapy. So it's all encompassing. But when to use these is really, I guess, the million-dollar question. So we are really inspired by this paper by Brian Reaney and Elizabeth Plimick, where they were looking to de-escalate away from systemic therapy. And the reason for that is the current systemic therapies for renal cell carcinoma are considerably toxic. They have 40 to 80% grade 3 toxicity rates. They're very financially costly, where the drug alone costs 100 to 300K per year, require monthly infusions, labs, visits. It's onerous on the patients, both on their bank account and on their ability to come to clinic. And the efficacy, although it's excellent and it's really moving the bar, it's not a cure for most patients. You do have PFS that usually lasts only 1 to 2 years. So what Brian Reaney and Elizabeth Plimick did was they took patients with low volume, defined as kind of a low number of centimeters of resist measurement, and they just did what they called surveillance on the patients with metastatic disease. And they took 48 patients as surveillance, and what they found was that by resist measurements, you could keep them progression-free for, on average, 9 months, a median 9 months, and you could keep them on surveillance for 15 months. But something interesting to note is, although the surveillance was a lot of imaging, it wasn't just pure watching with radiography. What they did in a number of these patients, but they did do local therapy, which is mostly resection and sometimes radiation. And they would pop, and there's more likely chance they also did that, before enrollment as well, which is not described. So surveillance, it does kind of get sprinkled in with mastectomies in this trial, but it gave us an interesting idea. What if we just kind of owned up to mastectomies and did that serially? So we designed and did a trial with doctors Tanier and Mazal over MedOnc in MD Anderson, and then Kanishka Sarkar in pathology really helped a lot here. And what we did was we basically took patients with low volume metastatic disease and we radiated all sites of the disease with biopsies, of course, too. And then at time of progression, we looked and saw if it's oligoprogression, less than 3 sites, then we went ahead and did it again. We did radiation again, and then kept this loop going as long as possible. However, if there was polymet progression with more than 3 sites of the disease, then we're kind of forced our hands, forced to start systemic therapy. And there's other criteria as well, such as local failure after radiation, et cetera. So this was the trial design that we did for our RCC oligomet protocol, which was basically testing whether radiation therapy specifically can be used in lieu of systemic therapy. And what we found was we enrolled 45 patients. We screened 45 patients and enrolled 30 patients. Of these 30 patients within our time frame of this study, 17 had 1 round of definitive radiation, while 13 had 2 rounds. Since then, it's been a year now of more follow-up, and we've had 3-4 rounds without too much difficulty. These are generally low volume patients. They're well selected and generally indolent. And a number of them did have systemic therapy or definitive treatment beforehand, which was local therapy beforehand. And so, in the beginning, it took 2 months to enroll like 1 patient, but now I get like 4 or 5 of these like a month. So there's a lot of these patients out there. But in terms of trial efficacy, we found that the median progression-free survival, which is I would argue immature at this point a little bit, was found to be 22.7 months. We'll see how this matures over time. OS at that time, 30 patients with 100%. Nobody passed away, and a year later, follow-up, nobody still passed away. Time of systemic therapy was quite good. We could maintain most patients off systemic therapy for a while. And I would hazard that we can keep most patients off for at least 2 years on this treatment. In fact, some patients, maybe indefinitely, a number of patients indefinitely. And because there is a lot of dogma around radiation resistance for renal cell carcinoma, we were asked to do repeat biopsies after SBRT 3 months afterwards. And what we found, and this is just a core biopsy, was that in 43% of the biopsies we did, they were negative malignancies, could be a miss. And the remaining patients, 57%, we did find, although viable cells at 3 months, there was a reduction in Ki-67, suggesting that there was a reduction in proliferation. So 3 months is probably too early to see cell death completely from this. We know that from other studies like David Palma's, non-small cell lung cancer trials. But it does indicate that biologically there's something happening, we believe, with SBRT. In addition, we found that even serial radiation was well tolerated. We had only 2 episodes of grade 3 toxicities, which is back pain and muscle weakness, which resolved, and 1 episode of grade 4 hyperglycemia, which required insulin, and that resolved, and the patient's off insulin now. So that was after pancreas SBRT in this case. So we have kind of taken advantage of momentum. It took us a long time to enroll those first 30 patients, but it's becoming more accepted to do this, at least in our institution. And now we are enrolling up to 100 patients, and we're, I think, 92 in at this point, with a second cohort of patients. And we're really trying to leverage these patients to get biomarkers, including blood and tissues, and really trying to understand genomically, based on you saw the first slide, what has happened in these low volume patients, and also see if we can really assess biologically if there's maybe a marker to find these versus the patients who progress more rapidly. So is oligometastatic renal cell carcinoma radiation new standard of care? I don't know. I guess you could argue based on NCCN guidelines that all this was, although there wasn't much evidence supporting it. But it's something that really, I think, deserves more interest and involvement. And I think there's a lot of patients out there like this who are interested in not continuing their IO doublets, indefinitely. So in addition to this trial that we did, Dr. Shankar Siva also published another trial looking at 30 patients, and this time added 6 months of pembro at the end of it. And it's really interesting given, Checkmate 526, I believe, the adjuvant pembrolizumab study, whether this is going to benefit the patients. This is a single arm study, and the PFS is encouraging, about 15.6 months, with also a very encouraging rate of grade 3 AEs, which is not very different than what we saw in our study. So more to come about whether we can kind of supplement radiation therapy with kind of targeted, maybe adjuvant systemic therapy bursts that are kind of finite in duration. So really quickly, also oligoprogression, another area for renal cell carcinoma that's a lot of patients. So I want to talk really quickly about Checkmate 214. This is Bob Matzar and his Artinier study. And what they did is took almost 900 patients with intermediate poor risk renal cell carcinoma, randomized them to Nivo-Ipi and then Nivo afterwards. Typo, for sunitinib. And what they found was that Nivo-Ipi worked very well. But in addition, in a exploratory analysis that we did and was presented at ASCO GU, we did find that a lot of these patients, 100 of them, they would just have a good response, and then they would fail in one new lesion. And it was a very common kind of recurrence pattern in these patients. They're getting IO therapy at least. So a number of studies have looked at whether we could just radiate this one site of oligoprogression. 2 phase 2 studies are available in this space. One is the Canadian study, which is by Chung et al. Up in the study book. And what they did was took patients who had stability on prior TKI therapy and up to 3 sites of metastatic disease that are growing. And then they just kept the patients on the same systemic therapy, which had to be a TKI, and then the radiation all sites of disease. So this study was closed early because the new standard of care for first line became IO, TKI, IO for the most part. So, but 37 patients were enrolled, 57 lesions were treated. And in addition, over in Dallas, Rakib Hanna recently published their prospective single center study, which is a little bit more modern, 20 patients, where they received either TKI or IO or IO TKI, and then were continued on that and treated to all sites of oligoprogressive disease, which is either 1 or 2 sites, so 29 sites treated. And what we generally see is very consistent, actually. You see that you can keep the patient on the same line of systemic therapy and just treat the progressing sites with a median time on systemic therapy of about 12 months, so 12.6 in the Chung study and 11.1 months in the Rakib Hanna study. Phase 2 single arm studies, but interesting as you go down the line to second line systemic therapy, it becomes less effective from there. So more to come in this space, hopefully. We did have a energy SWOG rad storm concept that we try to push through to kind of look at this a little bit more. Unfortunately, it's probably not moving forward, but that's okay. Hopefully new studies will look at oligoprogression in renal cell carcinoma. And then finally, one couple quick slides about debulking nephrectomies in the metastatic space. So as we know, SWOG and EOJC way back did nephrectomies and showed that in the setting of, I believe, IL-2 therapy, there was an OS benefit with nephrectomies. Carmena has kind of thrown that in a big loop because of the sunitinib land. There was no benefit in OS. But that doesn't stop us from doing trials. So there are 2 ongoing trials or in development trials looking at nephrectomies in patients who are getting IO-based systemic regimens. And there is one ongoing trial looking at radiation therapy for Nivo-Ipi. 78 patients, I believe, is halfway accrued, also in Canada. And they're basically getting SBRT to the primary kidney lesion and seeing basically, if that impacts, I believe, PFS as an endpoint. So we'll see more from this. In addition, from Energy GU012, this study is kind of, I think, should be undergoing its final parts of development, looking at a very similar picture, more patients, randomizing patients to standard immunotherapy, which is IO VEGF, versus that plus SBRT, 42 grade 3 fractions. This is a very common regime done, maybe popularized, I think, in Australia, and seeing if that improves in patient outcomes. So that's my 10-minute spiel, and I talk really fast, so I hope you all caught that. Here's my email for any questions, and much love from Houston. Sorry I can't be there in SWOG and in real life.
Thanks, Dr. Tang. In the interest of time, we'll move on, and Dr. Kirshner is going to speak about a trial that's been brought here before, the IO care study. And Austin, I'm going to go in parallel with you, so go right.
Okay.
Go
Can
right
you
ahead.
hear me okay and see the slides okay?
Yes.
Okay, great. So thank you for the opportunity to present this. This is a phase 2 randomized trial concept for immunotherapy and radiotherapy for oligoprogressive disease in the metastatic castrate-resistant space. So we abbreviate that IO-CARE. This trial is based on clinical data that's available from a similar style trial that was done as a large randomized phase 3 study several years ago, published and recently republished as a long-term update. So the CA 184-043 study, 800 patients randomized to 8 gray to a bone metastasis, followed by ipilimumab for about 4 cycles or maintenance thereafter, versus radiation alone to the bone lesions. They found that there was a difference in progression-free survival, but the median overall survival for the whole cohort did not make a big change. So it was not a game-changing approach that led to any kind of indication for ipilimumab in prostate. But this long-term data that was presented here in the recent manuscript showed that there was a tail that seems to be different, and there may be a signal of some patients who are responding in the long term to some immune propagating treatment. So there's a difference of around 7 to 8% or so in the overall survival going out to even 5 years. They looked at subgroups of their study that was a planned analysis, and they found that there was a significant improvement in the group that had more of what they called a favorable disease amount, where the alkaline phosphatase was not that abnormal, hemoglobin was around 11, and there were no visceral metastases. So these were bone-only patients. And there was a pretty large 7-month median survival improvement in that 288 patient subgroup. That, just to put into perspective, in this patient population that was heavily pretreated, including docetaxel, makes it on the spectrum of what is currently FDA approved for these agents, as I list in the bottom right here. Docetaxel has itself a 4-month median survival improvement in the castrate-resistant space, and several of these other agents are similarly approved in that same space for that same amount of improvement. So this wasn't a primary analysis of the study, so it didn't take again into approval status, but it was a very thought-provoking thing. And they did a separate study that was ipilimumab alone, just to see if that would provide a signal in these favorable group of patients with this limited amount of metastatic signal based on these lab values and no visceral disease. And they did not see a significant improvement in survival from ipilimumab alone. So there's a hypothesis that there's a combination of radiation and the ipilimumab that made the difference, not just ipilimumab alone. Radiation is not a very popular combo approach in many clinical trials right now going on with the immunotherapy space, but it's becoming increasingly popular. And we wanted to address this in a more thoughtful way, since these patients are progressing and are definitely at the end of line. Can there be something we can do to improve the combination approach of immunotherapy and radiation? So we took this work into my laboratory and designed several preclinical models that we could use to discover if there's a mechanism of synergy going on between the immunotherapy and the radiation therapy. There's one concept here which is known as the CGAS sting pathway, where the activation of the immune system can be triggered by the production of type 1 interferons by cells that are treated with the right kind of dose of radiation in the right way. And that's a way of saying we don't really know what that is, but we studied it in mouse models and we studied it in lab cell cultures with human cell lines. And we came up with these plots where we determined that there's a maximum amount of cytoplasmic DNA that's produced from certain radiation dose fractionation styles. And we think that the peak for you looking at 5 models of prostate cancer is somewhere around 13 gray. So giving a 13 gray fraction is the most likely, at least in these preclinical models, to stimulate the sting pathway to produce type 1 interferon, which can then go ahead and trigger some immune predilections that can help with treatment response. And then mimicking what we do in the clinic with all the studies we've been talking about today, there are many clinical trials and there's many doses and fractionations for SBRT approaches. And we found that by doing a 2-fraction 13 gray approach here on the table on the right, you can reach similar levels of BED with an alpha beta of around 60 for some of these palliative regimens, or over 100 when you think of the alpha beta of a 3, which is closer to what prostate cancer is. So we think that's a clinically reasonable dose. I mean, there are trials that use 12 times 2. This is just a smidge over that. We don't think it's too unreasonable to consider 13 gray times 2. And this is something where we don't know exactly how to space it. We thought spacing it every other day might be useful, or maybe doing it once a week could be even a reasonable approach, just to give time for the immune cells to be activated and then potentially leave the site, trigger additional immune cascades, and then have a second boost a week later, kind of like as a in situ vaccine approach. So here's just a little bit of the preclinical data in the mice showing that we treated the mice for about 1 week with a PD-1 inhibitor or a PD-L1 inhibitor, either one works, and giving doses of radiation. We did here sequentially 10 gray times 2, and we found that there was a significant improvement in the mice who were receiving this combo treatment versus the individual therapies. So overall survival was increased. I'm not showing here the tumor responses, but we did see local control as well as distant tumors in mice with 2 grafts that were placed with tumors. So there seems to be some immune-mediated effects. We analyzed these tumors and found that there was an increase in CD8 positive T cells in the irradiated tumors in the hind limb, as well as in the flank tumors that were not directly irradiated in the same animal. So there seems to be some systemic immune response. And we also proved that we could block that immune response by an anti-CD8 antibody being administered to the animals right after the treatments. And we found that they lost the survival advantage. So we're pretty encouraged to think that we're triggering some immune response, at least in this mouse model of prostate cancer in the castrate-resistant space. And then taking that into account, we thought, let's design a trial. So in the oligoprogressive setting, where there's patients who are on maintenance therapies and are having at least 1 to 5 new bone lesions by traditional imaging, we thought those folks could be a good target for receiving an ablative approach of SBRT to those new lesions, and therefore could maintain their standard systemic therapy at the discretion of the treating physician while receiving SBRT versus SBRT plus the immune checkpoint therapy. And we're not yet committed to one agent, but a PD-1 or PD-L1 agent that would be appropriate to combine. We would treat these patients with those drugs for 3 months, around 12 weeks, and then reassess with a bone scan about 12 to 16 weeks later and see if the lesions that were treated responded, if any of the other lesions that the body had could have responded, how their other factors are doing, such as PSA response and so forth. I'll show you on the next slide. We wanted to do a sort of dynamic minimization approach to make equal numbers of similar backgrounds of treatment, because this can vary in these late stage patients. How many second lines of therapy have they received? How many other agents have they received, like docetaxel, for example, just to try to balance out the arms a little bit as we fill the ranks on this randomized trial. And then so we would decide, if patients are responding, it would be based on the imaging approach. And there's a group called the Prostate Cancer Clinical Trials Working Group that has well described how to use these conventional imaging approaches, such as bone scans, to determine if there are new lesions, and we can call them progressive disease, in the sort of 2+2 algorithm, where you can have 2 new bone lesions and then confirm that on a second bone scan achieved about 8 weeks later. And then the data progression is the first scan. So you can do this sort of worldwide with bone scans that are available universally. We would love to discuss using next generation imaging, such as PSMA PETs that are becoming more common. But to make it widely available, this sort of conventional approach is what we considered as our first option. And we would have secondary objectives to determine survival, of course, in these late stage patients, the local control and the lesions treated, and then any non-irradiated lesions potentially responding if there is a systemic immune response, how the PSA changes, which can be quite variable, as we know in some of these late stage patients, may not exactly correspond to their disease burden, and then whether there are new lesions developing, and of course the safety. As we all know, SBRT is fairly safe, but we would be including that with the study. And then of course the very intriguing biomarkers that we could potentially pull from these patients, like their blood counts, which can correlate with immune responses, has been published in many different clinical scenarios. Such things as absolute lymphocyte count or neutrophil to lymphocyte ratios have relevance in immune responses. We can pull cytokine panels from serum. We could look at circulating tumor cells using conventional or commercially available assays, or T cell receptor sequencing, as well as circulating tumor cells, again, from commercially or otherwise designed circulating tumor assays. And there was one in particular, Cell Search, was sort of validated in multiple large randomized trials out of the national cooperative groups to correlate with overall survival, even though it's not the best type of assay for circulating tumor cells. And so here's our biostatistics that about 24 months, we could accrue patients over this time frame to monitor them at a 6-month time point. And our goal would be to have at least an increase similar to what was shown on that clinical trial I mentioned, where we would see about a 20% increase in progression-free survival at 6 months, hopefully matching that study and then doing a little bit better. if we can get a good combination of radiation and immunotherapy. So in summary, this is a potential approach that would be a lower toxicity than using immunotherapy by ipilimumab. We have preclinical data that sort of supports this combination approach, and we think that the high dose radiation done in a very thoughtful manner can help us with immune responses. And the primary outcome is progression-free survival of these patients who are late-stage oligoprogressive in the castrate-resistant setting, with a lot of secondary endpoints that we can use for more hypotheses and generating future studies. So I want to thank a lot of folks involved in the design of these studies and the preclinical work, and I'm happy to take any questions. My email's there on the top right. Thank you very much for your time.
Thanks, Austin. All right, so I know we're a little over time, so we won't do the backup dancers and the full orchestra.
Yeah, so thank you, James, and thank you all for being here. It's kind of exciting. Sorry about the technical difficulties we had getting through here. And it turned out, as I had sort of anticipated, many of the previous speakers showed many of the slides that I had showed. So I'm just going to show a couple of quick things here. I think, fundamentally the question comes, does control of local disease matter once patients have become metastatic? And I think that was something that fundamentally, when I started in this field 20 years ago, we sort of assumed it didn't matter. You had these sort of rare things like the nephrectomy and metastatic renal cell cancer, but for the most part, once they're metastatic, we gave up on them. And here are two randomized phase 3 trials that challenge that. On the left is the STAMPEDE trial for limited stage metastatic disease. This is not what we're talking about today. This is not treating all metastasis. This is just treating the primary. And what did you find? You found an 8% in survival at 3 years from essentially 5 radiation treatments and a 17% improvement in progression-free survival. So a very, very simple treatment that you can give to almost every patient had a substantial improvement. Think about the PSMA lutetium that was just approved. Hundreds of thousands of dollars over 36 weeks for a 4-month improvement in overall survival, albeit in a totally different patient population. So this is a very, very effective treatment in some patients. On the right is a similar study done in nasopharyngeal cancer. Again, patients randomized to radiation therapy to the primary site in patients with known metastatic disease. And again, a substantial improvement in progression-free survival and overall survival. So I think this tells us that treating isolated areas of disease provides a benefit. And then obviously the question is, should we treat more than that? Should we treat all the areas of disease? So this was a SABRE-COMET trial that was alluded to a number of times. This was up to 5 metastases of diffuse histologies. And what you can see is a substantial improvement in overall survival at 3 years from essentially 2 weeks of radiation therapy to 5 lesions. Patients could get whatever systemic therapy they needed. So essentially, RT wasn't needed in about 10% of these patients. About 25% of the patients did benefit. And of course, the issue is the vast majority of patients probably in the long run didn't benefit. And so that's the art of all of this. We need to figure out who these patients are that can benefit and how we can select them appropriately. This is a pooled analysis of randomized phase 3 trials of oligometastasis radiation in non-small cell lung cancer, which clearly demonstrated a benefit in progression-free survival and overall survival from 3 relatively small randomized trials. So again, this is an area that's rapidly becoming much more prevalent and into our armamentarium for many different diseases. This is a fascinating trial that actually may relate to something like prostate cancer. Where can we find a select group of patients that biologically are going to behave better and for whom we have effective treatments? This was a randomized phase 3 trial for up to 5 metastases for EGFR mutant non-small cell lung cancers. So patients here got an EGFR mutant targeting oral agent plus or minus radiation therapy. And what you can see, again, 3 to 5 radiation treatments over 1 to 3 weeks had an 8-month improvement in progression-free survival and an 8-month improvement in overall survival. So it's a substantial impact now established in multiple trials. Again, I think this is an issue of selection. You know, this is very much analogous to what we're used to in the PROTECT trial, where here we see patients treated or observed with early stage prostate cancer. And what you can see is the vast majority of patients could have avoided upfront surgery or radiation for their early prostate cancer, but a small amount of them could have benefited by early treatment. And in that cohort of patients, we're trying to figure out who they are, and the same thing here in the stereotactic treatment or ablative treatment for metastatic disease. I'm not going to show Dr. Tran's data, but intriguingly, they seem to suggest that there were genetic and or imaging markers that might select who to best treat. So I would say this is an exciting area. If you just do a quick search in clinicaltrials.gov and look for radiation and oligometastases, there are 163 studies going on internationally across all different disease types. However, we're also in a very difficult situation that this is becoming standard of care. As radiation oncologists, we are routinely treating these patients off of protocol. So it's going to be difficult to do many of these studies, and we need to really push to get the studies done before the cat is out of the bag, so to speak. For instance, on SWOG 1802, this is trying to mimic the experience that was done in Stampede, where we do local therapy to the prostate, either surgery or radiation. But there was such a strong belief among the study committee that oligometastatic therapy was important, that up to 4 lesions are allowed to be treated prior to enrollment, prior to randomization, with either surgery or radiation, because it was felt that if we didn't include that, we would lose patients. And so fundamentally, I would argue, and many of the speakers here have said, selection is really key. Who can we do radiation therapy alone to? Can we delay their systemic therapy? Can we keep them on the current therapy? Can we delay hormonal therapy, for instance? Who should we get hormones and radiation together? Whether that be immune therapy, as was just spoken about, whether that be checkpoint inhibitor therapy, whether that be androgen ablation, as we talked about in prostate cancer. And then how do we identify these patients? Should this be a biologic identification, genomics, a mutational strategy, circulating tumor cells, circulating DNA? How should we pick out these patients? Or should it be an imaging-based paradigm, such as we're just radiating patients with PET-avid lesions? So I think it's a really, really exciting area. I think there's the potential here in a select group of patients that we still need to find to make a dramatic impact in their quality of life, their progression-free survival, and even their overall survival. So that's my quick thing, no fireworks.
I know we probably have to leave this room so that the room can be turned around, but I just wanted to thank James and Dan for putting this on. We owe you a great debt. Just from a historical perspective, the first trial, phase 3, that I was the PI for was 8794, which was the adjuvant radiotherapy trial. And when I was a resident, I was taught seminal vesicle invasion was equivalent with systemic disease, don't bother. And it turned out that the adjuvant radiotherapy group that benefited the most, the numbers needed to treat to reduce mortality, was precisely that group of patients. You have to go back and look at the original publication. And remember that the GU committee was Bob Flanagan's interferon cytoreductive nephrectomy, and we're now doing the lymph node dissection, 1011. We finished that trial, that accrual. We'll see what the results are of that. And that certainly includes this as well. And there was one of the slides that was shown that suggested that the probe trial was in development. The probe trial is open. And I would encourage everyone to accrue to that, answer the question if it matters. And this, in 1802, there was a Latin American symposium. It is a high priority for being opened in multiple countries in Latin America. So I would just encourage the folks who are in attendance here personally, or those who are on, I saw there were 44 attendees on the Zoom. I'd like to charge James and Dan to lead the group, come to us with a concept. Let's take this to the next level, because there's no place that can do it like SWOG, and with Dave McConkey and his team developing that question of who's going to benefit, we have a remarkable opportunity. So I'm sure there may be some other questions, but I just wanted to thank you personally for all the work that you put in, and as well as all the speakers.
Yeah, for those that are online, if you didn't hear, that'll wrap up the session for today. Thank you for everybody that came in attendance, whether personally here or online. Our apologies for some of the technological difficulties. We're learning how to do life. Life in person was easy. In some ways, life in Zoom was easy. The combination of Zoom and in person is actually quite a bit more difficult from a technological standpoint. So our thanks to the assistants in the back who helped us struggle through it, and we'll all learn, because I think this is going to be part of life going forward for a while.